airway stenosis is actually known by various terms. So, various authors, various teachers, various surgeons, they do use various terms like laryngotracheal stenosis, subglottic stenosis, SGS, LTS. So basically, all these terms actually mean the same thing. That is the upper airway stenosis, which literally means that the any stenosis which may be either ranging from the supraglottis up to the carina. Okay. The slide is not moving now. Like, yes. So I would be trying to cover this topic under these headings where we'll have problem statement, etiology, clinical presentation, evaluation, treatment goals, surgical management per se, and post-operative follow-up and the results. So few, though there are a number of many slides are there, I would be sticking on to these slides which are actually important for the DNB purposes, and I might be rushing through few of these slides which are not that important. Okay. So LTS or the airway stenosis, it's a rare condition. So it's that not that common. Around 1 in 2 lakh adults, they do acquire the laryngotracheal stenosis. So it is a narrowing of the airway at any point between, as I told, between the supraglottis and the carina. Out of these, like out of 100 cases of stenosis, airway stenosis, around 80% of the cases are acquired. Now, this number 80% is not actually it's an average number which has been picked up from the various studies. So, the numbers quoted by various authors in the literature is from 82, from 60, 70 to 95%. So few studies have quoted that almost 95% of their cases were actually the acquired stenosis. And in day-to-day practice, it is also very common to see the acquired stenosis rather than the congenital stenosis or the idiopathic stenosis. So, and out of almost all of the acquired stenosis patient, they do develop acquired stenosis because of the prolonged intubation. Now, how does this causes stenosis? We'll be seeing through it. So, the important factors which make somebody or somebody's airway prone to the stenosis are the duration of intubation. Like there is a general consensus that nobody should be kept on endotracheal intubation for more than 10 days. And slowly, the threshold for tracheostomy vis-a-vis prolonged intubation, oral or nasotracheal intubation, the threshold is now lowering down. That means that the intensivists who are taking care of these patients who are there in the ICUs are now calling us early to do a tracheostomy. At many centers, they do tracheostomy on their own, which is actually the mostly the percutaneous tracheostomy. Now, the ETT size is also important. If somebody has put in a very big size endotracheal tube in the trachea, the person is more prone to develop it stenosis. Number of intubations, like a patient who has been intubated n number of times or has been given n number of trials. Traumatic intubation, like the trauma has happened during the intubation, movement of the ATT, the proper level of the sedation has not been maintained when the patient was on endotracheal tube, and the infections. All these causes are all these factors are important to cause stenosis or the post-intubation stenosis. The pathogenesis, what happens is that there is an initial injury because of the compression of mucosa by the ETT or the cuff. So ETT itself may directly hit onto the mucosa of the trachea, or the cuff pressure may actually cause necrosis of the mucosa of the trachea. So because of this necrosis, there is a decreased mucociliary flow, which causes infection. So there is like there is a complex event which happens, that there is an injury, there is a necrosis, and then there is because of decreased mucociliary flow, there is an infection, and because of this, the inflammatory markers or the inflammatory pathways are activated, which cause the granulation tissue to form, which tries to control that infection, tries to control that inflammation, and because of that exuberant granulation tissue, there is the contraction, and finally there is remodeling of the tissue, which results in the form of stenosis, which we do see during the endoscopy. So how do these patients present? Any patient with the upper airway stenosis or the tracheal stenosis, how do they present? Most of these patients will present with breathlessness or stridor, and there is like progressive, slowly progressive, or breathlessness or the stridor, which actually worsens when they do some strenuous work, like they are climbing on the stairs, like they are going for a jogging and all. So these patients will come that though at rest I am okay, my breathing is okay, but when I do any exhaustive work on or any exertion, when I take any exertion, then there I develop insufficiency of air. And in few patients there can be voice and swallowing difficulties, where the glottis is involved, or the parapharyngeal space is involved because of the trauma. And when you ask them the history, most of these patients will give the previous treatment history, either of the uh, mostly because of the prolonged intubation. Few of these patients may have already undergone tracheostomy or may have gone repeated endoscopic procedures, mostly the dilatation. So dilatation was earlier when there was not much knowledge or the awareness among the clinicians about the stenosis and the management options available. Dilatation was one of the procedures which was very commonly done, and was actually the reason for more severe stenosis. So we'll come to that later. So when we see these patients, we have to review their intubation record, that how long was the intubation, what all other pathologies were there, because it may happen that there was intubation, but actually this stenosis may have other reasons also, like the sarcoidosis or other autoimmune pathologies, or the vaginous granulomatosis. So we need to rule that out, that the history does fit into the post-intubation stenosis. Apart from that, we need to take the history of diabetes, cardiopulmonary disease, reflux, systemic steroid use, because all these factors are important when you are considering them for the final treatment plan. So when we see these patients, we have to observe for the stridor or the labored breathing, how much does the retraction is there. So it is a general examination, which is same as for any patient whom we do see in the stridor or the labored breathing. And the differential diagnosis obviously remains the same differential diagnosis which are there for the upper airway obstruction. So it is another cause of upper airway obstruction actually. And we need to examine or the observe the voice quality also, because that would indicate us that how is the laryngeal function of that patient. Apart from that, we need to thoroughly examine the whole of the head and neck region for the other abnormalities, especially in the patient when there is no history of intubation, or there is no despicable or the very distinctive history which indicates about the etiology or the cause of stenosis. So the next step comes is one. Now we have gone through that. How do they clinically present? They clinically present as the labored breathing or the stridor. What is the cause, or what is the most common etiology? The most common etiology are 80% of the cases are the acquired stenosis, and most of them are actually post-intubation stenosis. So these the two things we have covered. Now comes whenever we see a patient, the next thing comes to our mind is that now how do we evaluate further? So evaluation, whenever we evaluate for any disease in ENT, when we evaluate, we already have in our mind that what is should have our in our mind that what are our aim, what is our aim, and what are the objectives, what are the objective measures by which we are going to achieve that aim. So the aim in this stenotic patients evaluation, airway stenotic patient evaluation, is that we want to treat them at our best, and the best thing is that these patients should be managed in a single sitting, preferably in a single sitting. So whatever is about the treatment plan is that should be decided very cautiously after due diligence and a proper evaluation. So for upper airway stenosis, when we evaluate, our objective is that we need to know about the type of stenosis, whether it is a congenital or is a acquired stenosis. Where is it located? Whether it is a supraglottic stenosis, it's a glottic stenosis, it is a subglottic stenosis, or tracheal, purely tracheal stenosis, or is it a combined? So it may happen that some patient is having subglottic stenosis. Along with that, there is a glottic insufficiency also. The scar tissue has gone up to the glottis also. So we need to very clearly know that what all sites or the subsites are actually involved by the stenosis. Now the next thing comes is the degree of obstruction, that how much is the airway compromise. If we say that the lumen is 100%, so whether it is 75% compromise, whether it is 50% compromise, or there is no airway, there is a complete obstruction between the upper and the lower air. Then the next thing comes is the how much is the length. The length of the stenotic segment is a very important factor. For example, we can easily treat a very thin membranous stenosis involving a single tracheal ring. There can be many options to treat such kind of patients. But if, for example, uh, there is a hard or there is solid stenosis involving 4 or 5 tracheal rings, and it's a great for stenosis, matlab there is a complete obstruction. Now these kind of patients, they do not have various options. So they do have limited options. So it is very important to know the craniocaudal extent, that is the length of the segment which is involved in the craniocaudal axis, that is supero-inferiorly. Along with that, it is very important to, as I told, that it is very important to know the vocal cord mobility, whether it is a neurogenic analysis or the paralysis, or it can be, and it doesn't mean that it is always like that the vocal cord would be involved. Fortunately, vocal cord is mostly not involved, because once the vocal cord is involved, vocal cords are involved, these cases are become difficult to treat. As you know, if both the cords are involved or both the cords are not moving, there would be a glottic insufficiency. Okay, so if there is abducted paralysis, the cord will be in the abducted position. These patients will have problem of aspiration. If it is an abductor paralysis, the cord will be in adducted position. So whatever you do in the lower airway, your at the level of the glottis, there would be an insufficiency. So in such kind of patient, you need a treatment modality which can treat both the things, or you have to treat both the things separately. So it is always very important to document these 5 things. Along with this, if there is a previous tracheostomy, we need to examine the tracheostoma and the peritracheostomal region. So how do we examine? We'll further get to know that how do we examine these things. But it is very important to document that what is the health of the tracheostoma. what is the health of the cartilaginous ring, tracheal rings, which are in the vicinity of the tracheostoma, because it can further complicate our surgical management. So now we know that the goal, what are the aims, or what is the aim and what are the objectives of our evaluation. Now, how to achieve these objectives? How do we know that what is the craniocaudal extension? How do we know that? So the first thing comes to our mind is that we should go for a radiology. Radiology is good as far as it is concerned, or it is taken as the primary investigation or the first investigation or the OPD basis investigation. But it is never a gold standard, because a CT scan or an MRI cannot tell you that how is the feel of the tissue which is there inside the trachea or in the subglottis, whether it is a soft stenosis, whether it is a hard stenosis, whether it is a dilatable one or whether it is a not a dilatable one. So radiology does corroborate our findings, and it does tell us about the other anatomical landmarks which are there in the neck, but it is not the gold standard. The gold standard always remains a rigid endoscopic evaluation under general anesthesia. So when we see these patients first, if patient is in severe stridor, we try to get a chest X-ray done to just have a rough idea that what is the site of stenosis and what is the length of stenosis. So this is very important. If you have time in OPD, we should always try our best to get an idea of that what is the site and what is the length of the stenosis, because this patient is already is in stridor. We are going to take him or her into OT, which is again is a stress to the patient, and patient is likely to have more need of the oxygen, will have more changes in the hemodynamics. And if we do not know precisely that where is the stenotic segment, uh, sometimes it can be very tricky to do even a tracheostomy. Okay, it may be a complete stenosis. We opened the neck, we saw the trachea, we incise the trachea, but when we incise the trachea, you find that there is no lumen to put in your tube. So, if possible, always get an X-ray neck in AP and lateral view. That is the minimum thing which one should do. And if possible, if patient is not in very severe stridor, you can get an CT done. It is better to get a CT done. That is in the on the OPD basis. And if patient is in stridor, obviously we have to go for tracheostomy. If possible, it is always preferable to uh, not to be very far away or very lower down than the stenotic segment, because when we are going to do a tracheostomy, we are again actually damaging a few more cartilaginous rings. So it is the best is the that if you uh, if you incise at the level of the stenosis itself, and in a controlled way you can put in a tube, that is the best possible thing. But that should be done in the presence and the supervision of the experienced surgeons who have experience in dealing with these kind of patients. Otherwise, it is safe to be to do a tracheostomy in a safer region. So this is for the patients who come with a severe stridor. Fortunately, not all patients do come with the severe stridor. Patients do come with the labored breathing or the shortness of breath. In these patients, we do order a CT scan, and we on OPD basis we have to do a fiber optic laryngoscopy, and if possible bronchoscopy. With our experience, it is preferable not to do a fiber optic bronchoscopy in a Ziffy in these patients, because if it is a grade 3 stenosis, or sometimes in even in grade 2 stenosis, the injury caused by the fiber optic bronchoscope itself can be an inciting event for patients to develop severe stridor, and sometime many a time there is not enough time even to shift the patient from the bronchoscopy suite to the uh, OT to do a tracheostomy. So what we prefer is doing a fiber optic laryngoscopy or a 90-degree laryngoscopy on in the OPD basis. Here we document all the things which we document for any other patient with a laryngeal pathology or the tracheal pathology. So we see the larynx, we see the evaluate the supraglottis, we evaluate the glottic ching, we evaluate the chords, how are the chords, and whatever subglottic we can see through the chords. So this is the OPD evaluation of the stenotic patient. The gold standard always remains a rigid endoscopy evaluation under the general anesthesia. So we get a pre-anesthesia checkup for these patients, and in a controlled environment, in a normal your elective OT, you have to take these patients. The anesthetist should be very well explained that what we are going to do, and how much time we are going to take, especially if your patient is not tracheostomy. If your patient is tracheostomy, it is okay, it's a safe procedure. They would induce the patient through the tracheostomy tube, or they can put in a fiber optic uh, tube through the tracheostoma, and you can evaluate. So this is like any other. So we have one has a long telescope which is known as tracheoscope. It's a 0-degree scope like the nasal endoscope. The only thing is that the length is uh, it's a longer telescope. So with your left hand, if you are a right-handed person, with your left hand you have to put in the Macintosh laryngoscope, uh, see the vocal cords, and through the glottic opening, you have to introduce your telescope and examine the examine the whole of the larynx and vocal cord, subglottis, trachea, and go. And if the patient is tracheostomy, you can momentarily remove the tracheostomy tube and go up to the carina. So your evaluation should always be from the vocal cord or from the supraglottis to the carina. Now, what all things are to be seen and what all things are to be measured? So when we are doing a rigid telescopy, we have to measure few measurement. We have to take few measurements, like, and that should be very precise. So one should be, your first thing should be the vocal cord. The next thing should be the start of your stenotic segment. So from the place where your stenotic segment is starting, so distance between the vocal cord or the lower surface of the vocal cord to the upper end of the stenotic segment. Then from the upper end of the stenotic, if you can pass your telescope through the stenotic segment, so you have to, in that case, you have to pass through the stenotic segment, measure the length from the start of the stenotic segment to the end of the stenotic segment. The next measurement would be from the end of the stenotic segment to the, just a minute. So first measurement would be from glottis to the start of the stenotic segment. The next would be from start of the stenotic segment to the end, that is the length of the stenosis. The next would be from the lower end of the stenosis to the upper end of the tracheostoma, then the length of the tracheostoma, and from the lower end of the tracheostoma to the carina. So these are the four measurements which we have to properly, precisely measure and document. So how do we document? I'll show that how do we document for how should we documenting for these. So when you do these two things, a precise surgical strategy can be made at this time, taking all parameters in account, like the vocal cord mobility, which we have seen in the fiber optic laryngoscopy, extension and degree of stenosis, location of the tracheostoma, length of the residual normal trachea. Yes, that is very important. And the segments of the tracheomalacia, if there are any. So this is one of the. So this is one such endoscopic assessment. It was a 7-year-old child who had Guillain-Barré syndrome, was intubated for some time, and once it was removed, after some time, he developed uh, respiratory distress. So he came with the respiratory distress. We did the tracheostomy for this child. So what you are seeing is, this is the vocal cord. This is the vocal cord or the true cord. And this is in the immediate subglottis, you can see this is the stenotic segment or the stenosis. So it is less than 4 millimeter. Our scope of 4 millimeter is not, we are unable to pass through the 4 mm scope. So this is how one should be documenting the results or the findings of the endoscopic assessment. So this is the true cord. From that, the stenotic segment, this is the stenotic segment which you are seeing. Just a minute. So this is the stenotic segment. So the length of the stenotic segment is 3 centimeter from the lower end of the stenotic segment to the carina, that is 4.2 centimeters. So that is how we measure. Now the same thing can be seen, or can be, our findings can be corroborated with the radiology. As I told that we initially get done an chest X-ray. Usually the CCT neck and thorax is usually sufficient. MRI is not required in these patients, mostly not required in these patients, until unless that you are suspecting the mediastinal pathology or the mediastinal stenosis, where there is an additional advantage of doing an MRI. Or we are thinking of some congenital anomalies, then again MRIs are added in addition to the CT scans. And in few cases, you can do a virtual bronchoscopy, which is actually a 3D reconstruction of the airway. So this is again one of our patient who developed tracheal stenosis. This patient actually, this lady had, she had COVID, and almost for around 1.5 months she was in ICU, but fortunately she recovered. But then after a few days she started having respiratory distress, and when we did examine and do the scopy, we did find that there is a stenosis in the mediastinal trachea, actually thoracic trachea. So the differential diagnosis, as I told, are like for any other upper airway obstruction causes like laryngomalacia, tracheomalacia, vocal cord paralysis, cyst or collapse of the airway, vascular compression, any mass in the larynx, infection like the epiglottitis, GER, tracheitis, malignancy. So these are the causes which may actually also present um, as the stenosis or the differential diagnosis for the airway stenosis. But as I told that almost 80 to 80, more than 80% of these patients are actually acquired stenosis, and most of them are after the either after the one or the other form of the trauma. One, either it can be the intubation trauma. So most of these patients are actually post intubation trauma, or some other fine kind of trauma like the strangulation by the dupatta or some those kind of things in India. So now when we do the scopy, we do the endoscopy, we need to grade the stenosis. The most commonly used grading system is Cotton-Meyer grading system. Another grading system which is used by few authors is the McCaffrey grading system. So Cotton-Meyer grading system is a simple grading system which actually only takes the only considers the level of obstruction or the grade of obstruction. So if there is, this is the tracheal lumen, that means it does measure only the lumen. So this, if this is the 100% lumen, if it is 50% there is obstruction, so 0 to 50% is grade 1, 51 to 70% obstruction is grade 2. So white part is the actually the patent airway, the black part is the stenotic part or the obstructed part. So 50 to 7% is grade 2, grade 3 is 71 to 99%, and if there is no detectable lumen, like if we put in endoscope and it hits a soft wall with no lumen to go through, it is a grade 4 stenosis. So we do see all these kind of patient. Grade 1 patient usually do not present to the clinicians. Grade, it is mostly the grade 3 or the grade 4 patient which we do see. Fortunately, we do see sometimes grade 2 patients also. So this is how a grade 2 subglottic stenosis looks. This is how grade 3 looks, and this is the grade 4, as I told, that there is low lumen to pass your endoscope or any instrument. So as I told, Cotton-Meyer grading system is the based on relative reduction of the subglottic cross-sectional area. It is good for mature firm circumferential lesions. It doesn't take into account the extension to other subsites. Like as I told that if there is scar tissue involving the subglottis and also the glottis, the results are poor, or the management is relatively difficult than a pure subglottic stenosis. But our Cotton-Meyer system doesn't consider this. If there is glottic stenosis along with the subglottic stenosis, it will only consider the lumen which is available for air to pass through. But it is gold standard in pediatric patients, and actually it is the most common grading system which is used by most of the authors. McCaffrey had an observation that the cross-sectional area is not the constant predictor of the or a reliable predictor of decannulation in adults. That means the results solely doesn't depend upon the cross-sectional area which is available. So he proposed a grading system based on subsites, where it subsites like trachea, subglottis, glottis, and it included whether it is involved and also the length of it. It doesn't include the lumen diameter. So if you see that stage 1 is confined to subglottis or trachea, that means the stenosis is only in the subglottis or the trachea. Okay, this is the cricoid, this is the cricoid, and this is your stenotic, a small stenotic segment. If it involves the more than 1 centimeter, but it is confined to the cricoid, it is stage 2. If it goes down and involves, if it goes down and involves the trachea, it is stage 3. If it goes up and involves the uh, glottis, it is stage 4. So, so he concluded that if glottic, tracheal, subglottic is the major factor, involvement of these is a major factor in type of surgery. If it is thin subglottis or tracheal lesions, he said that endoscopic management can suffice. But if it is thick, that is the thickness of the stenosis is more than 1 centimeter in any side, or if glottic or that is vocal cord is involved, then endoscopic management is not usually sufficient. One has to go for open surgical procedure. And he also told that this 1 and 2, stage 1 and 2, that is the places where only the required or a part of trachea is involved, then 90% patient can be treated successfully. But if your scar tissue is going and is involving the vocal cord, only 40% of the patient can be decannulated successfully. So this is the evaluation part. This is the grading, that how do we, when we do an endoscopy, once we have done the endoscopy, how do we grade our patients? Now the next thing comes is, we have evaluated now. The next thing comes is the treatment options. So the goal of treatment in airway stenosis is that we need a patent airway. Patient who is on tracheostomy should not be on tracheostomy. Along with that, there should be a glottic competence, because that is the whole problem. Patient is breathing through the tracheostoma, but is unable to use his vocal cords. So we want vocal cord to be used, but at the same time, we do not want patient to be aspirating. So, and along with that, we want that patient should have an acceptable voice. So the primary goal is that there should be patent airway. Along with that, we want that the airway should be protected. The airway protection mechanism should work fine, and patient's vocal cords should be functioning fine. So this is the treatment goal for these patients. The most important thing which we all should always keep in mind in cases of laryngotracheal stenosis, the best chance for patients lies in a successful first surgery, which implies that the surgeons should be, the person who is treating these patients should be fully trained in upper airway endoscopy 1 and the laryngotracheal surgery 2. Because inappropriate initial management of subglottic stenosis may lead to permanent intractable sequelae. We all know that whatever we have done, whatever we have achieved, whatever the science has developed, but we have not been able to actually create an artificial trachea which is acceptable to the human body. Neither we have been able to develop an artificial trachea, neither or nor we have been able to reconstruct the trachea with some other tissue. Okay. So the every tracheal cartilaginous ring is very, very, very precious. We should not be wasting even a single cartilaginous ring by doing the procedures just on the presumption that, okay, there is grade 3 stenosis, I will dilate with the bogies, and patient should be okay. That doesn't happen actually. And the worst thing to happen with these patients is that most of these patients uh, do get a dilatation treatment and actually develop more severe stenosis. So that is why it is important. Not all of us would be treating these stenosis patients, but we should be knowing that what is to be done, what is not to be done. So we should know that what are the management options. How do we manage upper airway stenosis? The options are medical management. The options are observation only. The option is tracheostomy only. And then there are definitive treatment options like endoscopic treatment. That means that the airway recanalization of the airway can be done by the endoscopic measures or can be open airway expansion procedures. Medical treatment is actually not exactly for the to treat the stenosis. It is the adjunctive treatment where we think that the other um, other elements might be contributing to the severity of stenosis like gastroesophageal reflux. So we need to treat the gastroesophageal reflux. There may be other pathologies or the other issues in, especially in the pediatric patient. So we need to consult the pediatrician, the pulmonary people, the cardiology people. We need to assess the general medical status, give that the treatment. If the lung function is not good, you have to improve the lung function. Now coming to the actual management. So observation only, that means that a patient is having stenosis and we say that, okay, you do not need a treatment, we can observe. So observation is an viable option in patients where there are very mild symptoms or symptoms in very, very strenuous exercises like the grade 1 stenosis. Grade 1 stenosis, this is if there is no retraction, if there is no feeding difficulty, there is episodes of group, patient is following the growth curve. That means that his or her airway stenosis is actually not causing any effect on his general health. And we can do a repeat endoscopy. This is especially for the pediatric patients. In adult patients, again, observation option can be considered depending upon the symptoms, depending upon the general medical condition. Like if somebody is of age, say example 75, was intubated because of a stroke, now extubated, developed subglottic stenosis, short segment, is doing fine because his other uh, general physical condition is not allowing him to go for a walk, to climb the stairs, and he or she is otherwise okay with his daily chorus activities. Observation only is a very good option because at age 75, you're not doing an extensive surgical procedure is again not a very good option. So, coming to the actual surgeries for subglottic stenosis or the laryngotracheal stenosis, as I told, it can be endoscopic, it can be an open procedure. The most common procedure which is done endoscopically is the dilatation. Earlier, what used to be used was a were the rigid bogies, whether it was metallic bogies or hard silicone bogies. Now these bogies are no more used because they are traumatic. There used to be an inadvertent trauma to the vocal cords, to the supraglottis area, to the area which is actually not stenosed. Now what happened? Now today what is preferred are the balloon dilatation. Balloon dilatation, the balloons are like the balloons which you see for other procedures. These are very thin walled balloons which can be which are dilated with the saline. These are high volume, low pressure balloons. So with the endoscope, one does put in a guide wire. On this guide wire, this balloon goes and then it is dilated, kept there for some time and then removed. And this procedure can be repeated. Okay. So in few patients where a sufficient dilatation has been achieved, we may consider stenting the stenotic segment. Silicon tubes आती है, which are the Montgomery tubes or the T tubes. I'll be showing that figure very soon. So those once you have dilated the stenotic segment, you can just put in a T tube. Now this stenotic segment can be released with a laser or coblation or cryo or radio frequency, and an stenting can be done. So the most common procedure which can be done endoscopically, that is without opening the trachea from the front, are the dilatation and stenting procedure and laser or coblation cryo RF, that is removal of the stenotic tissue and stenting. The other procedures are the open procedure. These are actually the expansion procedures where you remove the tracheal or you remove the stenotic segment or the tissue which is causing the stenosis, and then you do the reconstruction. So it can be laryngotracheoplasty. Okay. It can be laryngotracheal reconstruction. It can be tracheal resection with primary anastomosis. So I'll not be going to into very much detail of this. I'll just be showing the steps of one such procedure. So what are the advantages of endoscopic approach? The best advantage of the endoscopic approach is that there is lesser morbidity. The anesthesia risks are lesser because the procedures are usually short. The hospital stays are short. Patients do return to their work early. There is tolerance of repeated procedures if necessary. But as I told earlier, that this is not the elixir for all the patients. So patients who have to undergo dilatation should be chosen very, very wisely. So as I told, the stents can be the most common stent which we use are the silastic T tubes. These are the bioinert. These are made of the bioinert material. Body usually do not react to these stents, and they can be kept for longer periods. Like we usually prefer keeping them for 6 months, but they can be kept up to 2 years without causing any other issue. In few patients where there is a malignant obstruction, the expandable stents can be used. As you can see, this is the stent which is there in an unexpanded form. These stents are usually made of nitinol. Okay, it's a metallic stent. It is made of nitinol stent. And this is the silastic T tube. So this is the T tube. It has got a vertical limb. It has got an horizontal limb. Horizontal limbs comes out from the tracheostoma as our other tracheostomy tubes. But unlike the normal tracheostomy tube, which has only one limb which goes down, it has another limb which goes up. So once we recanalize the stenotic segment, we put in this stent or the Montgomery tube, and then we this end has an option to remain open or can be cocked with a cap. So this is kept closed so that patient breathes normally through the nose as the normal patients. So as I told, the lasers can be used. The most commonly used lasers is carbon dioxide laser for this procedure. Nowadays, coblation is also very commonly used, which has got laryngeal bands. The laryngeal bands are used to treat these stenotic segments. So this is how a laser is used. So this was an stenotic segment. The laser is used to inside, give one incision like this, another incision like this, another incision like this. Then additionally, it can be dilated with the dilators or the balloon dilators, and then this can be used. Montgomery tube can be used. So laser procedures, endoscopic laser procedures. um Endoscopic laser procedures have got around 65 to 80% success rate in properly chosen adults. It is mostly used in grade 1, grade 2 stenosis. Failures can be there if there is a loss of cartilage support, there is too much of circumferential scarring, there is a retinoid fixation, there is exposure of cartilage. So these are the bad features. Now, certain drugs, as you know, are used to basically to counter the restenosis. The most commonly used drug is mitomycin C. It is an antimetabolite which is the from the Streptomyces caspitosus, and the mechanism involved triggering of fibroblast apoptosis. So what it does is that it actually causes the apoptosis of the fibroblast. So the new fibrotic tissue is not formed. It inhibits the formation of new uh, fibrotic tissue. So there, the studies which where it has been studies along with the CO2 laser, the successful 50%, 15% of the patients had a successful outcome. Along with the steroid injection, 18% had successful outcome. But with mitomycin C, 75% patient had successful outcome. Here, the successful outcome means that the patient could be decannulated. So these were the similar patients who underwent either CO2 laser alone or CO2 with steroid injection or CO2 with mitomycin C. So this is an study by SAPSE published in 2004, which clearly establishes the supremacy or the non-inferiority of the supremacy of the mitomycin C as compared to the steroid or the CO2 laser only. This I have already covered. So endoscopic procedures are this endoscopic removal of stenosis often leads to good short-term. As I told, the short-term results are good, but mostly the long-term results are not that good. So all these cases where the endoscopic procedure is not preferred, the open surgical approaches are preferred. There are basically three open surgical approaches. They can be classified into three procedures. One is standard cricotracheal resection. It is the technique of choice where the scar tissue involves only the or the primarily the anterior subglottic area. But when there is extensive involvement along with the extensive anterior subglottic area, like the lateral cricoid space, cricoid is also involved. There we require an extended cricotracheal resections. And in cases where it is too much extensive, then there is we need laryngotracheal reconstruction along with the rib cartilage interposition. So these are the three procedures. So this is one of the procedures where there was tracheal stenosis involving the two tracheal cartilages. This is superior, this is inferior. This patient was tracheostomized, and for the procedure, we did remove the anesthetist did remove the tracheostomy tube and put in a flexometallic tube from the same tracheostoma. So this is superior, this is inferior. There you can see the cricothyroid muscles over here. This is the first tracheal ring. The second and third tracheal ring were involved with the stenosis. So we have given an incision over here, given an incision over here, and you can see that there is a lumen seen inferiorly, there is a lumen seen superiorly. This is the stenotic segment, and we have opened it vertically also, and then we did remove the segment. So once we have removed the segment, you can see that there is discontinuity between the lower segment and the upper segment. So these are the two tracheal rings which we did remove. Now there is total complete disjunction between the lower trachea and the upper trachea. What we are seeing behind is the esophageal wall. Okay. So then these two ends are sutured. If this segment is long, the removed segment is long, we sometimes need to release the larynx from superior attachments. That is known as the supraoid and infraoid release. If the segment is around 2 centimeter or 3 centimeter, the only the lateral release with the finger dissection does give a additional length so that these two ends can be sutured. So as you can see that these two ends are approximated and then they are sutured. So this is how it is done. And here we have removed the flexometallic and put in a T-tube. The upper segment, upper part would be going here, lower part will be going towards the carina. For during the procedure, for proper uh, inhalation and anesthesia, we have closed the upper end so that the air should not be releasing through superiorly. So once this is a case of tracheal resection and end-to-end anastomosis. So the best results are achieved when there is purely tracheal uh, stenosis, and the best procedure to do in these cases, if it is a grade 3 or 4 stenosis, the best procedure is to do a tracheal resection and end-to-end anastomosis. Almost 3 to 5 centimeters of trachea can be removed and can be end-to-end anastomos in a good way. So coming to the end, that how are the results or the outcome? What are the results or the outcome measures? Obviously, the primary goal is that the patient's respiratory function need to be improved. Patient should be off tube, that is to achieve decannulation. And along with that, the secondary goal is that the patient should have good speech and the swallowing outcomes. So speech and swallowing outcomes can be measured objectively by using the voice handicapped index, eating assessment tools, and then there can be sensitive instrumental assessment for dysphagia and dysphonia like fiber optic endoscopic elevation, which is known as FEES, modium, modified varium swallow, or acoustic analysis of voice. Thank you. Any questions? Hello. Hello. Hello.
Yes, sir.
Are there any questions?
Trainee, ask your doubts in the chat box.
Can't see.
Sir, there is no more query. I think we should wait for 1 or 2 minutes.
Okay. So there is a query that how long will it take a patient to recover after suprahead release? See, most of these patients, if you do only a suprahead release, most of these patients usually do not have any significant issue, because that is one of the common procedures which we usually do along with the lateral tracheal release by the finger dissection. Sometimes when you combine both the suprahead and the infrahead release, and if you if you go a bit aggressive and go much deeper to have more length of the trachea, actually few of these patients may actually have issues with the swallowing. As you know that, as we know that the during swallowing, larynx has to move up and out. So that function is lost once you do both a suprahead and an infrahead release. And that has happened once that that lady had to undergo intensive swallowing therapy to recover from this procedure after an supra and infrared release. But most of the time, it doesn't usually cause a problem. But swallowing, yes, swallowing can sometimes be affected, mostly when you are doing both the procedures, that the suprahead and the infrahead release. Okay. The next is the what should be the position of neck after tracheal resection anastomosis? Yes. So that slide I just missed. That post-operative management, the most important things in the post-operative management is that one should not be extending the neck. So uh, before taking patient to the OT, that is during the counseling period, we always tell our patient that you will have to keep your neck flex for quite some time, especially when you are in the hospital. If we think that patient has not understood it very well, or patient is like very strong, very hefty, and will not be very cooperative in the post-operative period, we sometimes consider either taping the side of the face or the chin to the chest, or maybe sometimes taking those sutures. But that is something from outside. What we do inside is that once you do the anastomosis end to end, when you suture the two tracheal ends, so these are the PDS sutures which are very good in their tensile strength. Along with that, what we do is that not at those ends, but like this is one end, this is the second end. We take one suture much above, and that is the 1O silk or the 2O silk. We take it from here and from down to down on both the sides, right and left both. So that is like an additional strength to the trachea or the tracheal sutures. So this is one thing. Another very important thing is that these patients should be started on very intensive um, pulmonary rehabilitation. That is the what we do with the these balls respirometry. Okay, that intensive respirometer should be given to all the patients, because these patients are a bit prone to develop pneumonia, especially if you are keeping them in the ICUs. So we mostly prefer that these patients should not remain in the ICU not more than for overnight. So most of our patients usually do come back to our ward after the OT. If any of them has to go to the ICU, that is only for the observation, overnight observation. Next day morning, they will be brought back, because these patients are prone to develop pneumonia, and you do not want that to happen, because once your patient start coughing, there would be issues. So that is, I think, the last query. Do we need to take any specific care in patient with short neck? Not actually, not any specific care in the short neck patients. I couldn't understand the last query by Dr. Jackson Choi. So do we close now? Hello.